I'm Sean O'Driscoll, a professor of orthopedic surgery here at the Mayo Clinic and specialize in elbow and shoulder surgery. I'm discussing a paper that we recently published in the Mayo Clinic Proceedings entitled Patient-Physician Agreement Using Summary Outcome Determination Scores. There are 4 points that I would like to make about this paper that contributes to our practice of medicine, not just here at Mayo Clinic, but anywhere where this would be instituted. The first is that this is a value-based aspect of looking at the evaluation of clinical outcomes in surgical patients. And of course, it does not need to be limited to just surgical patients. The second is that it's patient-centered. The third is that it's simple and clear and can be easily implemented to normal clinical workflow. And the fourth is that it's independent of the condition or the severity of the condition, so that it adjusts automatically to whatever condition you're evaluating or whatever level within that range the patient functions. So first, I said that it's value-based. And we are in an era right now in which the delivery of medical care necessarily must be focused on value. And so whereas we normally tend to look at outcomes in surgical patients as success or failure or degree of success, we have to start looking at them to the value that they deliver to the patient. So for example, I have an operation I do on the elbow that I also do on the shoulder in arthritic patients. In the elbow, I would call this operation an 8, meaning that in general, if a patient has this operation, they would tend to value it as 8 out of 10 on a scale. And if I do the same operation on the shoulder, I would tend to refer to it as a 4, meaning that patients in general will value it at about a 4. Now, value brings into consideration the aspect of patient-physician agreement. And patient-reported outcomes have become very, very important because we've realized that the outcome that a patient assigns to a procedure or an intervention is often different from the outcome assigned by the doctor. And in fact, it's generally accepted that doctors and patients don't agree on the outcomes of surgical procedures and perhaps medical interventions as well, or other types. And that raises the question of just why we don't agree. Is it that we really don't understand what the patient wants or values? Or is it that we really value something different altogether than what the patient values? I think that the training of a doctor is such that we should be able to understand, and I do believe that we do understand, what is important to a patient. So what this means is that what we're evaluating in outcomes is probably different than what the patient is evaluating. So as a surgeon, say doing elbow surgery, I would value things like the range of motion of the elbow following the surgery, and whether the elbow is stable or it dislocates still, whether it's painful. Patient might value something else very differently. Let me take, for example, somebody I just operated on. He's one of our law enforcement officers in the federal system. He had a serious injury to his elbow. It was badly broken, very badly broken. Was close to unfixable, and indeed it was not able to be fixed anywhere near adequately with the first attempt 5 months ago. And he was referred to me with a painful elbow that only moves through a small portion of the arc of motion. It dislocates at times or partially dislocates, and he has a severe problem with the nerve as well that goes past the elbow. When you look at his x-ray, clearly he has an arthritic elbow that needs to be fixed or replaced. When you ask him what matters most and get a list of priorities, he would tell you that the #1 priority that would affect his quality of life is the lack of flexion, meaning he can't get his hand anywhere close to his body or his face. And that would be his #1 priority, is to recover flexion. His #2 priority would be to have an elbow that doesn't slip out of joint and cause him to suddenly lose the ability to use the hand, because he has essentially stopped using his hand because of that unpredictability. Now, I would have thought that the #1 priority was pain relief, but it turns out that was actually his #3 priority, and maybe even the 4th, because the nerve problem in his hand was such that he was losing function in his hand, and he told me if he could get the other 3 corrected, he could live with the pain. Interestingly, what I thought was his #1 problem was not at all his #1 problem. In fact, by prioritizing this way, using this system of evaluating patients, we necessarily have to get into their minds and understand what matters to them most. In other words, what they value most. He could tell me in advance what he would score his elbow. He told me he would score his elbow as greatly improved if we accomplished that. Now, I had thought I was going to have to replace his elbow because of the pain of the arthritis. Turns out we didn't have to do that at all. In fact, that would have been a disservice to him because it would have put a lifelong limit on the use of his elbow. So it's patient-centered, it's value-based, and third, it's simple and clear. The concept of evaluating outcomes is to simplify it to the point where it is very clearly understood by both the patient and the doctor, and that agreement between the two should be expected rather than uncommon. So the agreement was quite profound. The agreement was perfect in about 3/4 of the patients, meaning that the doctor and the patient, or the physician assistant, or the resident or fellow, and the patient agreed on the outcome in about 3/4 of the cases. Now, we also agreed, if we just ease off the restrictions slightly there, we agreed within 1 point, meaning we were in the same category, or if we're not in the same category, we were still within 1 point on a 10-point numerical scale 98% of the time. So a 98% of perfect or near perfect agreement is a remarkable correlation between a doctor evaluating the outcome and the patient evaluating his or her own outcome. And so what happens, you have a scale that stretches out. You have a scale that stretches out the outcomes. So when we think of outcomes with surgery or intervention medically, the first question we ask the patient is, compared to before your surgery, are you better, worse, or not much different? And not much different would include you're not sure if you're better or worse. Now let's assume that they're better. The next is to pick a category of one of 4 levels. And we ask the patient, are you improved, greatly improved, almost normal, or normal? And we tell them that normal means as though they've never had surgery, they've never had a condition or a disease or an injury. The difficulty in picking a category is not great. It's very clear to most people which category you're in. But it does require that you understand how the patient was before surgery. So it necessarily drives the doctor to inquire about the preoperative status when you evaluate them as well. It requires that you go back and look at the priority. And it also has an internal consistency check. So we ask the patient the questions in terms of which 4 categories they would fall into. And then we ask them a numerical value. So I say, well, if 10 is perfectly normal and 0 is just like you were before your surgery, what number would you give to your elbow now, or to your knee or your hip? And so they pick a number. And a 10-point scale is a familiar concept to patients from the pain scales and other scales. So if the patient says, I would rate myself as improved and 8 out of 10, then you wonder, okay, so why are they only improved and not greatly improved if it's 8 out of 10? So it permits an opportunity to verify what you have just heard from the patient, and therefore be very clear as to outcomes. Finally, it's independent of the severity of the condition or the condition itself. Scoring systems are very often dependent on the actual condition or the procedure that has been done, and therefore they have limited applicability across systems. What we would like to be able to do is to value an elbow replacement in a person crippled with rheumatoid arthritis and compare the value to society of that operation to the value of an operation done on an elite athlete, or the value of a medication prescription in somebody with another condition. Ultimately, that will help us to make wise decisions in the delivery of health care. In summary, the summary outcome determination that we have reported is indeed a summary outcome determination. In other words, it's like saying, when all the dust is settled and all is said and done, what was the impact? What was the value? That's what matters to the patient. That's what matters in health care. And that's what matters as we move forward trying to derive values for the health care measures that we implement. Ones that we have been implementing and are now looking back and trying to determine how they fit in as we move forward in the future.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, Our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.